Hi, everyone. Thanks for joining. We're going to wait a minute or two just while more people join.
It's in a green hanging thing on the bench.
I think we're good to go, Stephanie.
Great. Hi, everyone. Thanks so much for joining. If you can go ahead and enter your name and organization in the chat, super helpful for us to know who all is here today. Robbie's here with us. He's recovering from being sick, has very little voice, so I'll do most of the talking on his behalf today, but encourage Robbie to furiously use the chat as we go along. But really excited to see you all. We have a great agenda today. We're going to follow up on the bill we spoke about 2 weeks ago, Assembly Bill 1011. Some representatives from Find Help joined us last time to talk about that, and it seemed appropriate for this group to sort of regroup, keep that conversation going. We're also going to spend some time debriefing and recapping the CDII meeting that happened this Monday, the Joint Implementation Advisory Committee PNP subcommittee meeting. We'll be joined by Carrie Sanders from CPEN to talk about the OMB proposed race and ethnicity standards at about 11:30. So keep an eye on the clock to make sure we get a chance to hear from Carrie, and then dive into a few federal policy updates as well as state legislative and policy updates. Next slide, please. About the coalition, welcome to anyone who's new. If this is your very first time ever joining us, please feel free to put that in the chat. Super excited to have you here today. Our vision is that every Californian and their care teams have the information and insights they need to make healthcare and social care and all sorts of care seamless, high quality, and affordable. Next slide. Great. So let's get started by coming back to Assembly Bill 1011. As I mentioned last meeting, Find Help joined us to talk about this bill. It's the Social Care Data Privacy Bill. The bill would require individual consent for organizations that are participating in closed-loop referral systems in order to access identifiable information or social care data. In our last meeting, a couple key comments and questions were raised from you all about this bill, which included first, perhaps that the issue may need some additional study or attention because of the many different privacy and confidentiality laws in place in California. A question that was raised in our last call was, do we need to further solidify the issue and the fix that this bill is trying to address? Second, as we are all very aware, CalAIM is being implemented right now. Additional best practices around sharing social services information are likely to emerge and could influence future policy related to this topic. Third, a question posed by coalition members around how do we balance the need for individual consent with the needs to share information for individuals' benefits. And lastly, just general comments and discussion around the application of this bill to closed loop referral systems, not the social care system entirely. And so a question just to consider on how to balance that focus. Donna, I see you have your hand raised.
Yes, hi everyone. I just want to make sure before this conversation moves forward that everyone is aware, and might not be because this just happened this week, but there were some significant amendments taken up in committee that have changed the direction of this bill. And so before the conversation moves forward on the privacy and consent piece, I just want to reiterate for the group that the direction that Dr. Weber has decided to move the bill, of which we are fully supportive of, is stripping it down to solely focus on defining a closed loop referral system and then prohibiting the sale of data within these systems. And so the bill is moving forward with much narrower language to start. She has publicly committed to moving forward and returning to the consent issue in the future, but it won't be in this legislative vehicle. It would probably be next session or next year. And so we think that this is a really great direction for the bill to just kind of provide some of those guardrails initially, but leaving that broader privacy and consent conversation to ensure that it reflects both stakeholders and also the other work happening. And so I know that there were some concerns that were brought up on our last coalition call. And I hope that this does kind of ease some of those concerns and also clarify the direction that this will be moving. And so it got out of Assembly privacy on Monday, 11-0, no votes. And the amendments, I hope, are in print now. Robbie, it looks like you're seeing those. So that's great. And happy to answer any questions if it would help, but I just want to make sure that before the conversation continues, that everyone knows that narrower scope.
Thank you so much, Donna. Yeah, super important context. Well, maybe we can just start there. Any questions for Donna around those amendments that she just spoke about? Okay. Not hearing any questions on that. I think with the new scope in mind, coming back to this conversation around what additional points would coalition members like to be raised in any potential letter that might be submitted to the legislature. And then, I'm guessing folks maybe have not had a chance to read in depth the amendment. So maybe we'll take a pause on this third question that's listed here on should the coalition take an official position, but we'd like to come back to that for sure at some point too. But just on this first one, are there additional points that coalition members would want to ensure are raised to the author's office or in a letter that Connecting for Better Health puts together? No? Okay. Well, we'll come back to this. And thanks, Robbie, for throwing the, I am seeing. Donna, can you explain the reasoning behind the amends and the focus on the sale of data?
Yeah, absolutely. So I think the author recognizes that closed loop referral system has not been defined in statute and that it's pretty broad. And so I think that this was kind of a starting point. When we approached this, we were interested in looking at these technology systems as they are rapidly evolving. And there really isn't much kind of regulation or framework or guardrails around them. And so as a starting point to really just focus on the data being shared within these systems, and then also ensuring that I think Dr. Weber and we agree that this is a bit of a gap in California's consumer protection laws, that there aren't currently many protections for the data shared within these closed loop referral systems. So as a starting point, she felt, and we agree, that prohibiting consumer sale of data within these is a pretty solid protection that hopefully everyone within this field can get behind. If there are any concerns around this, absolutely, we would love to hear them. I know she would love to hear them before it gets to the floor next month, but it seemed to be kind of a common sense starting point to continue these conversations on social care data sharing as it evolves, and hoping to continue those into next year as it revolves on the framework and kind of all of these other pieces together. And so happy to hear any feedback or questions specifically, but we we felt good about the direction that she wanted.
Recording in progress.
Oop. And hopefully that answers that question.
Thanks, Donna.
Yeah, absolutely.
Any last comments or questions for Donna or the group around this Weber bill?
This is Mary Sarah Jones. My only concern is this is going to require consent with each referral. No, this will just be a one-time consent.
Sorry, I just want to clarify. I think the slide is maybe confusing the conversation.
Okay.
The consent piece has been taken out of the bill. So there is no consent element to AB 1011 after the amends that came through committee on Monday. So as of now, AB 1011 is solely defining closed loop referral system and prohibiting sale of data within those systems.
Okay, great. I was concerned about the impact to the end customers. Thank you.
Yes, thank you, Robbie, for that clarification too. So yeah, I think the language got shared above, and I'll bump it back down. So there we go.
Thanks, Donna.
Yeah,
One
absolutely.
other question in the chat. What about fees for data sharing for closed loop referrals?
That has not been addressed in the bill, so it shouldn't, I don't think that should change anything from how it was set up before. So you can look at the definition there, and I think if there are questions around that definition, the author's office is open to feedback there. I'm not sure if there will be other opportunities to kind of amend that in at this point, but I highly suggest if folks are concerned around the definition that is moving forward, that they share that with the author's office.
Great. Well, thanks so much, Donna, for the updates. And we will make sure that we return to this bill and the updated language. Appreciate those amendments. Thanks. Okay, I think we can move on. Thanks, Robbie. Great. So for the next 15 or close to 20 minutes, I think we can really spend debriefing Monday's CDII meeting. I know many of you were of course in attendance. So just I'll do, sorry. Oh, Felix says in the chat, linked language reflects the language presented at last call, not the most recent amendments. Are we still waiting for them to show up in print, Donna?
I thought they were, so let me reach out and send to the group. Oh, you're right, it does look like this. Yeah, so this is not in print yet. So I will flag for the coalition once those are in print. It should be any minute. And I can share the language with the coalition via email as well.
Great. Thank you so much.
Sure.
Great. Okay. So quick updates from the meeting, and then really, want to open it up and have a conversation with those of you who listened in and participated and have questions about the meeting. I am hoping to not do most of the talking here. But so on Monday, some updates shared by CDII. First on the DXF grants info. More guidance is supposedly coming this week from the state with additional details about the grant program, including some details I know many are eager to see. But confirmed that required signatories of the DSA will be prioritized in these first rounds of funding, which will total around $47 million through the end of the year in 3 different rounds. And then the bulk of Monday's meeting really dug into a couple of the policies and procedures still being finalized. First, the technical requirements, P&P, the real-time P&P, info blocking P&P, and early exchange, which we can talk about now. Next slide, please, Robbie. Great. So starting with the technical requirements, CDII clarified that the link moving forward is with not requiring hospitals and EDs to share ADTs with a QHIO, although requests for ADTs can be made by participants and QHIOs, sorry. And as was raised by many during the meeting and in public comment, there's a continued need for clarification on whether requests can be made for all three events, admissions, discharges, and transfers, inclusive of all three events. And, you know, there continues to be a lot of conversation around the ADT piece. We've had it here in Connecting for Better Health. It was definitely raised by many people on Monday. So we really wanted to open it up to the group now to just hear from all of you, your thoughts and concerns after Monday's meeting, specifically on the technical requirements PNP, and then we can move on to the next few. So I'll pause here, and if anyone wants to jump in, just go ahead and raise your hand. Felix, go ahead. Felix, go ahead. Uh-oh. Felix, are you able to hear me?
Yes, sorry,
Okay,
Stephanie. You're
great.
coming in
No,
a
no
little bit
worries.
faint there. Yeah.
Oh, sorry.
I did, yeah. Well, yeah, I guess I'll be brief. Basically distill the comments that I made, not just on behalf of Manifest MedX, but really the wide swath of stakeholders that express strong support for keeping the requirement for ADPs to go through a digital safety net of QHIOs. We think that's one of the underlying values of having a QHIO designation process. And I think, you know, we obviously heard, you know, at the meeting from some of the disappointment coming from a lot of the care teams that stand to directly benefit or not benefit from whether or not the ADTs can get to them when they need it. I think APG, the health plans, some of the FQHC and community health center partners all expressed, you know, the real, you know, gaps that are going to be left open by the state taking this decision. And the thing that I wanted to impress in terms of my statement on the decision was that not only is this going to create or perpetuate a burden for, you know, those recipients of the ADTs, but it will actually make things harder for hospitals in kind of the new paradigm of the DXF to handle all of the panels that will be coming their way. You know, as QHIOs, they'll be left with no other recourse except to actually send our panels, sometimes, you know, on the order of millions of patients to the hospitals that are not sending us the ADT feeds willingly. So there's a little bit of irony, well, not a little bit, quite a bit of irony, because really it seems like this will create hardships for everyone across the board, especially the hospitals sending the ADTs, versus had they had chosen to, you know, cooperate and collaborate on you know, sharing data through this common infrastructure. So yeah, you know, again, nothing new from what I said at the Monday meeting, but I wanted to obviously reiterate that with this group. And I do thank the coalition for being part of the voices that called in and expressed, you know, support for, you know, the need of ADTs to go through QHIOs or a you know, a common ADT hub.
Thanks, Felix. Any other thoughts? Okay. Next, we can talk about the real-time exchange PNP, the conversation around this. The revisions outlined by CDII at Monday's meeting around the continued efforts to come to an agreed upon definition of real time included first a 2-minute time frame to respond to a request on treatment, and second, a 1-week time frame to respond to requests other than treatment. So conversation at Monday's meetings, questions and comments raised around those two timeframes, is 2 minutes perhaps reasonable or not reasonable in many different scenarios. And then on the flip side, some folks shared is 1 week, too long for those other purposes of requests. Second, notice of admission or transfer events to happen at the time of the event, but notifications of discharge as soon after the event as practical, but not to exceed 24 hours. So a question that was raised in Monday's meeting was about the difference between discharge notifications, why they are not required at the time of the event, in the same way that notification of admissions or transfers are currently included. And then third, a comment raised in the meeting around potential need for further alignment with the federal info blocking rules and ensuring that the language is aligned. So again, I'll pause here. Would anyone like to echo comments that they made in Monday's meeting around the real-time exchange P&P, ask questions, or share any further concerns? Let's see, chat. Jonathan says 24 minutes. Do you mean 24 hours, Jonathan, or minutes? To 48 max hours seems reasonable. Do you want to speak to that one, Jonathan?
No, I think that there's a large disparity between 24 hours and a week, right? So like 24 hours to 48 hours max, right? Because there's other considerations in terms of like any discharge notifications that are given, and like care providers, you guys that are directly providing care would know more about this than I would. But I mean, it just seems like, giving a window of 24 to 48 hours gives a reasonable time to respond. And then also the opportunity for anybody else who needs to access that information to know, look for it in that time frame.
Thanks, Jonathan. Comments or responses there before we move on?
This is Jen with Aliado South. I'm just trying to figure out why we are not leaning on the federal definition, although admittedly, right, many federal definitions are very squishy in a lot of manners, but I'm really struggling with the fact that we're trying to, the pendulum has just swung the other way, right? We asked for a little bit more definition in this PNP around, what does real time actually mean and what is a reasonable time frame? But the fact, I feel like now we're just completely gone the other direction on trying to nail it down too much. And so I need to go back and really relook at my comments and thinking about these things. But I feel like we just really need to push for alignment with existing regulations, especially in this area, because ONC has already talked about this around the information blocking rule.
Thanks, Jen. Other thoughts?
I think as ADTs extend beyond just clinical partners, there's a lot of use cases where if they are timely, they could add a whole lot of support and take a lot of the lift off of the hospitals. One such use case might be, for example, housing. If you had an ADT that was shared with the housing coordinator at the point in time that a patient is admitted, if that's done timely, that allows that housing coordinator to get there and help support that patient before they're discharged. If it's 48 hours, chances are they're going to be discharged before they know.
Thanks, Mary Sarah. From Robbie in the chat, it sounds like developing firm timeframes may take time for the PNP. Yes, thanks, Robbie. Seeing no other hands here, I think we can head on to the next slide, Robbie. Great. So on the QHIO PNP, I think the QHIO PNP is fairly short. A lot of the real, meaty information that we've been discussing here, and the letter that Connecting for Better Health submitted earlier this year on this is probably related more to the information coming out in the QHIO application. And at, just sort of a first read through the QHIO application, which is out for public comment right now. Public comment is due May 15th. Connecting for Better Health is intending to provide public comment, and we'd love to talk more with you all on how to work on that draft collectively. But the initial analysis, just based on a first read of that application, and then love to hear what takeaways you all have had if you've had a chance to read the application. First, that the weighting and scoring rubric felt unclear, may need some additional details. Second, that there's a potential for perhaps a more robust or a separate QHIO PNP or other kind of regulatory guidance document to go along with the application. Third, that the application mentions participatory governance and consumer perspectives for prospective applications, but without clear definitions around what that might mean and how that will be demonstrated. The application mentions high trust certification in the Connecting for Better Health QHIO letter. If you remember, we suggested potentially offering multiple pathways on that. So would love to hear, if you all feel like high trust is the correct one to include here, or if there are additional certification options that should be included in the application. And that lastly, the application does not have clear requirements outlining, the need to include all potential signatories to the DSA, or to be able to demonstrate the ability to share social services information. So as I mentioned, those were kind of high-level takeaways at first read, but would love to hear what others thought of this application. And we'll of course continue this conversation in advance of that May 15th deadline. Anyone have thoughts on the application? Haven't dug in yet, but will soon. Great. Probably any folks. Felix, go ahead.
Thanks, Stephanie. I heard that this time. Thank you. So yeah, I think all of the bullets here that you outlined are spot on. They largely track with some of the points that we identified, and we have gone through the application as well as the corresponding PNP. I think some of the issues here actually cross-reference or actually tied to some of the other points that we would make, particularly in the last bullet. We totally agree that it seems like, based off of the previous draft of the application that the CDII shared, that there's been a walk back, right? Before the former draft said that very clearly that a QHIO could not discriminate in a sense or exclude any willing participant on the basis of geographies, size, or organization type. For instance, you cannot call yourself a QHIO or seek to become a QHIO if you only serve PCPs and provider practices, but not health plans, or hospitals, but not public health departments. Now the language in the revised draft of the QHIO application states that, well, if you want to restrict or limit services or exclude certain DSA signatories from using your platform, you just have to disclose that in your application. That really seems to violate the whole spirit and the whole principle of equity that the committee and CDII adopted in terms of the foundations for a robust and effective QHIO program. And I think it speaks to a larger point. What is the state looking for in terms of technical capabilities, but also driving organizational governance and motives, right? Quite frankly, for the applicants for this really important, really crucial infrastructure. We and others have previously advocated that the state should require QHIOs to have a nonprofit governance structure versus and be California based versus being nationwide or out of state in scope, and also versus being publicly traded or venture capital financed. And I think that speaks to, again, this issue of deciding whether or not to require QHIOs to serve all participants. We know that some services will be likely profitable and some may not be, and that should not be the bottom line in that sense should not be the determining factor of whether a QHIO decides to extend services to a type of participant. So we'll definitely share more of our thinking in further calls as the coalition discusses the application. But we think it all basically, again, fits together as part of a larger picture. If you want good governance, if you want representative and participatory governance, and if you want equity in terms of what a QHIO provides and whom they serve, you really need to be looking carefully at things like governance structure and nonprofit status versus for-profit and other similar issues.
Thanks, Felix. Any other last thoughts on the QHIO piece before we move on? Okay, well, we'll certainly be following up. Really encourage everyone to dig into the application, share your thoughts over email with Robbie or me or all of us. And we'll look forward to being in touch with you all ahead of that May 15th deadline. Great, and it looks like, really quickly, before we move on, just a quick roadmap of the upcoming implementation advisory committees and PNP subcommittee meetings to come throughout the rest of the summer. You should all have this slide to hopefully refer to if interested of what's coming up next. It looks like the next meeting would be the PNP subcommittee meeting on May 25th. Okay, great. So I see that Carrie Sanders is on. We're really grateful to welcome Carrie Sanders today, who's the Senior Policy Director, the California Pan-Ethnic Health Network. Many of us know Carrie well, I know, to talk about the proposed OMB rules around race and ethnicity data. 2 weeks ago, we had a brief summary from Olivia on our team on what these rules look like, and Carrie's going to share a little bit about some CPEN-led advocacy on this issue. So Carrie, welcome.
Thank you. Thanks for having me. And nice to see everybody on the call. Carrie Sanders with CPEN. As Stephanie mentioned, folks may be aware that the Federal Office of Management and Budget recently put out a request for input on proposals from the Federal Interagency Working Group on Race Ethnicity Standards for revising those standards. And for folks who may not be aware, those standards have only been updated 2 times since they were first put together. Initially, the standards were formed in response to civil rights laws in 1964. They were updated or drafted in the 70s, updated in 1997. So that was over 25 years ago. And then here we are today. So this is the second big update to that. We are, we've joined others in drafting letters. We'd love to have, the California C4BH group sign on to this. But in particular, we are, highlighting, I think, some of the main key points that the task force is proposing to revise, including the use of a single race ethnicity question. Currently, if you look at the way these questions are asked on census and other survey documents, there's a separate question for ethnicity. That's usually asked first, followed by race. And one of the things that, research has uncovered over the years is that's very confusing for folks, particularly, in the Latinx community. It's not clear if they're supposed to answer both questions and what that connection is. And so the census has tested using a separate question and has actually found that the response rate is much, much better. And so that is one of the proposals. The second proposal is to add a new Middle East North African category. And if folks may know, with the way the current categories are drafted, that MENA category is the folks who identify as Middle Eastern North African are currently, the option is to check off white, which is also not the way a lot of folks identify. And so adding this as an option, we hope will help to improve response rates. Just quickly, some of the other, again, Stephanie has really outlined this pretty well. So I won't, take too much of your time. But we do, we are asking for a collection of more detailed race and ethnicity categories, so we can really understand what identify and address granular disparities at the granular level. We want to make sure that that there's good guidance on the federal data collection and limiting of the use of estimations, which we know that self-report is really the gold standard, as well as for them to consider additional data collection needs of small communities, and to create a standing working group, because again, 25 years is a long time to wait to update these standards. So with that, just hope that folks will approve the coalition signing on to this. We would love to have you, and comments are due today. So this will go directly to OMB after this call. So thank you.
Thanks so much, Carrie. Does anyone have any questions for Carrie? Great. So staff recommends adding the Connecting for Better Health name and logo to this sign-on letter. As Carrie mentioned, it is due today, so it's quite a quick turnaround. But just wanted to pause and see our folks in support of Connecting for Better Health signing on. If you want to just use the thumbs up reaction or chat, anything like that. See a couple thumbs. Does anyone have any concerns about signing on? Okay, Great. Well, we'll move ahead with adding our logo to this letter. Thanks, Carrie, so much for your work and for making time to join us today. Really appreciate it.
Thank you.
Great. Okay, Robbie, we can move along. Great. So wanted to spend some time on 2 federal updates here. These are both proposed federal rules that have comments due at later dates in June, but wanted to get the conversation going. The first one, this OCR proposal around amending HIPAA to strengthen protections for reproductive health information. The intent of this is really to protect people's protected health information when there's an investigation or a proceeding underway, might be happening in another state, in particular around reproductive health and abortion access, and wanted to in particular draw our attention to this piece around defining certain terms. That's a large component of this notice. How are we updating terms such as natural person, public health activities, child abuse, and reproductive health care? So this comment letter is due by June 16th. It's linked here, and we'll put the link in the chat as well. I wanted to hear, one, if any organization that's on today has been closely tracking this issue, if you have dug into the rule in detail, would love to hear from you and any priorities that your organization might have around this issue. And then second, I think we can talk a bit about next steps in getting together a Connecting for Better Health letter. But to start, is this something that anyone on here has really dug into or organization is planning on weighing in on? All right, not hearing anything. I think there are, oh, thanks, Robbie, for putting in, the reproductive health issue brief that was released in 2022 from Connecting for Better Health. Robbie just added in the chat. I think there's 2 potential pathways for submitting comments. One, Connecting for Better Health staff could work on a first draft and just circulate it with you all. Or the second option is if we would want to schedule a dedicated ad hoc meeting to this rule in depth. Great, thanks, Jennifer. So would love to just hear, first would be really interested to hear what your members share with you and how we can uplift similar concerns or align our letters. And then on the second piece, is this of interest to members in having a specific ad hoc meeting about to spend really an hour digging in on this? Or are you interested in just reviewing a draft letter from staff?
Stephanie, I would say maybe if staff is willing to pull together a draft letter and then maybe having an ad hoc meeting if there's questions, maybe that might be a better use of people's time, but I don't want to commit anybody else's time to writing a letter, right, if they don't have the time to do it.
Thanks, Jonathan. Right. So starting with the letter and then seeing if folks have serious questions or concerns on a draft, we can revisit that at that time. That sounds great. Okay, then we can move along to the next slide. Similarly, another large federal comment opportunity that I want to hear if anyone has dug into or this is of high priority. And then also, are you interested in Connecting for Better Health submitting a letter about this topic? Should we have a specific conversation dedicated to this ONC proposal, which is really around the health IT certification standards for EHR vendors, and updating those standards. One piece, just based on some of our more recent conversations, I wanted to highlight was this bullet around decision support interventions and predictive models. I know we've touched on artificial intelligence and machine learning a couple times in recent months in this coalition, which is included as a standard that potentially needs to be revised and updated. And then it also, the proposed rule also includes clarifying information blocking for each. So similar questions here. One, is any organization, dug into this and is tracking this? Robbie says ONC just had a webinar this morning. We can maybe share that recording when it comes out. Okay, then looks like, yeah, Robbie added in the chat, we can do something similar for this proposal. Does it sound good to all if we start with a draft letter and then revisit if there are serious questions or concerns that may warrant a specific meeting on this? This one we have until June 20th, so we have a little bit more time here. Vincent, reviewing HIMSS. Oh, excellent. Yeah, thanks, Valerie and Vincent. Would love to see your comments or discuss further as your teams dig in. Thank you. Any final thoughts on either of these federal updates? No? Okay, I think we can move along. Oh, yeah. Go ahead.
Does anybody on the call feel like there's been significant amount of time for there to be traction to go back and track the metrics of the progress of this? Or are we making changes, or are there changes being made just to make changes? And I'm asking this from a completely uneducated layman standpoint on this. Like, I would like to hear anybody else's thoughts on that. For the ONC proposal, for the changes for the ONC proposal.
Thanks, Jonathan. So for the ONC proposal, any thoughts on if we have metrics to track?
Right, Robbie, I understand that some of these things are required under the Cures Act, right? But asking them to update it and change it every 6 months, right? Has there been a feasible amount of time that there's been a framework that's been established or a track record that's been established to actually make sense of any changes that would be made? I mean, that's the question that I'm asking. So I guess my other question would be is, if they're making changes just for the sake of making changes, have they even measured the effectiveness of what it is they've asked people to do? Right, that would be my concern, right? If you've not measured the effectiveness of what you've asked people to do, and then you're just implementing changes, like, it feels like you would be able to lose more traction than you would gain. That would be my concern.
Thanks, Jonathan. +1 on that in the chat. Valerie. Valerie, do you want to speak to this comment at all?
Just briefly, that I recognize, I mean, we haven't made like significant movement for instance, on information blocking. And so to your point about metrics and how far we've gotten thus far as we're just starting implementation, I think is a really good point, and probably something that we should elevate in comments to the ONC. I know there has been a bit of movement around some of the modernization work for electronic case reporting, for instance, on the public health side. So I think there are some particular ones that could be called out in terms of having made traction in light of the PHE and the PHE ending. And so moving forward, what we want to see as a community and how that, how just to push forward. So I gather that is probably a part of what they're looking for. But generally, in your overarching point, I do agree. But I also agree that's something that we have to make sure is highlighted, that we're giving the practice community, the public health community, enough time to realize specific outputs or outcomes. And oftentimes we don't necessarily see that in these programmatic, streamlined programmatic approaches. So that is, I think, worth just mentioning and communicating with ONC. So that's all I was gonna just say about that.
Well, and I appreciate that, Valerie, and to piggyback on Donna's initial comment, right? Like, making it simpler, I think you can always make it more complicated later, but if you just make it more complicated up front, like, people that are slow to adopt it are just going to have one more reason not to do it, right? And so those of you that are more closely attached to it probably have more feedback on that, but I just think that making it easier on people rather than harder to adopt newer standards means that you actually have to give them tangible information on what you've measured and then what you're asking them to do.
Yeah. Exactly. Yep.
Great. Thanks, Valerie and Jonathan. Okay, Robbie, I think we can move on. Just the last couple minutes of our hour here. Few state legislative updates. Let's see here. Just wanted to draw your attention to two in particular. Assembly Bill 352 from Bauer Cahan's office was recently amended, potentially has some implications for the DXF, and with the definition of sensitive services. And so we are reaching back out to Bauer Cahan's office. Would love to invite them to come to Connecting for Better Health and share a little bit more about these amendments. I think last time we met, this was still a spot bill that didn't have much in it. And then second, just wanted to mention that AB 1331 did pass out of Assembly Health Committee on Tuesday. Next slide, please. Or actually, Robbie, maybe we go back. Any comments or thoughts on Assembly Bill 352 or 1331? Anyone who attended the hearing or listened in on Tuesday that wanted to share anything there? Nope. Okay, we can move on. Additional bills, Senate Bill 313, the AI bill from Dodd's office that we spoke about before did pass Senate Judiciary. We're continuing to keep watch of that bill. In addition to Senate Bill 582 from Becker's office, who we also heard from a few weeks ago, did pass Senate Health. And then the trailer bill on the data exchange framework, no updates to share there, but thank you all to everyone who signed on to that letter, and we'll continue. There was some amendments on SB 582. Right, okay, updated, yeah. Seen here in the summary. Just an FYI, since this was a piece that we did talk about when we dove into this bill in more detail last month, that vendors would not be required in statute to sign the DSA outright. Thanks, Robbie. Any questions there? Okay. We'll just wrap up quickly noting a couple events that are coming up in May, where we'll be May 11th, a Manat webinar, May 17th, a CAP seminar in Burbank, all about data sharing and exchange, hoping to see a lot of you there. And then an additional event in Sacramento on May 23rd, State of Reform. There will be an interoperability town hall, which we will be at. Any folks on here planning to attend either the event on the 17th or the 23rd?
I didn't see the photo base of it too.
Considering the 23rd, great. Well, hope to see a few of you there. Look forward to it. And I think we're just, we can wrap up for the day. Here's just a couple new articles and blogs that have come out recently. Encourage you to click through the links on any that you're interested in reading. Specifically this third bullet here, this GAO report that came out recently around electronic health information exchange increasing, but the disparate increase experienced by small and rural hospitals. Encourage everyone to check that one out. And I think that wraps us up for the day. Thank you so much for joining. Anyone have announcements or upcoming events that they want to share? Okay, great. Then we're all done. Thanks, everyone. Have a great rest of your day.